So the first question I want to ask the audience here today, do you think that AI has a role in improving and assessing the quality of care? How many here? Show of hands. Okay, so I would say that's the majority, but maybe there are a few holdouts. So we're going to ask the same question again at the end. The next question, though, I want to ask is, how many of you use tools like ChatGPT or Gemini to ask and answer clinical questions today? So that's interesting. I'm seeing maybe a quarter to a third of the audience, which is really quite interesting. So I want to take you back in time a little bit to when my career started, which was during my residency at Stanford and the publication of the landmark Institute of Medicine report to Err is Human, right? Estimating that we kill 100,000 Americans on an annual basis, a 747 full of people going down on a daily basis. The follow-up report in 2001, Crossing the Quality Chasm, suggested that electronic health records and technology might be part of the strategy to reduce those errors, right? And so I worked very hard on some important CPOE projects and other things to help reduce medication prescribing errors and hopefully medication harm. And so it was a little bit ironic when 15 years after this publication, I was hospitalized with 2 broken arms after a bad bike accident behind Stanford. Now, because I had upper extremity injuries, I did not fall under the ortho protocol for DVT prophylaxis, because theoretically, I could have been walking around. And in reality, I had a couple different surgeries and a couple different dates. I was doped up on Dilaudid. I wasn't walking anywhere. But nobody noticed that, and I didn't get TEDS or SCUDS or DVT prophylaxis, right? So what happened? Week later, get some knee pain. As a pediatrician, I figured maybe they missed a knee injury. My internist friend said, or maybe you have a blood clot. And sure enough, I went back to the emergency department and found that I had a very large clot in my leg. Fortunately, it hadn't propagated and given me a PE. Now, Stanford actually pioneered the venothromboembolectomy, and so I was fortunate that the interventional radiology team was able to take that clot out, and I don't have long-term sequelae. But I was rehospitalized, underwent a very expensive procedure. I was on anticoagulants for over a year, all because of an avoidable medical error, right? And this happens every day in hospitals across the US. This wasn't unique to where I was, right? And that's the first point that I want to make today, is that despite the best of intentions, despite 20 years of investments, and not just IHI work, but lots of different Sepsis 5,000 lives, or 5 million lives campaign, and lots of different work, we have not made enough progress. Now, experts will tell you that there are areas in safety that we have made progress and we should be proud, right? So we have absolutely reduced hospital-acquired conditions. We've impacted central line-associated bloodstream infections. We've reduced ventilator-associated pneumonia. We've made progress, but we haven't made nearly enough progress. In fact, it wasn't until I became the chief medical officer at UC San Diego Health that my eyes were opened to the number of settlements that quietly occur on an annual basis at hospitals across the United States. What are those settlements for? Missed diagnoses, delayed diagnoses, things that we don't even bother fighting because we were in the wrong, right? And that data is not public. We're very proud that on our Vizient Q&A accountability dashboard, we're actually leading in the country. We're top 10 in Vizient among academic medical centers, and we've sustained that for 5 years. And yet some of those patient safety indicators are reflective of what we can measure rather than what we're actually delivering, right? And so it's for this reason that I got together a couple years ago with my colleague, Dr. David Klassen, a giant in the field of patient safety, and Eric Thomas, editor of BMJ Quality and Safety. And we wrote about this, and using some funding from Robert Wood Johnson Grant and the Jewish Healthcare Foundation, David had convened some thought leaders in both AI and patient safety, putting together 2 camps that don't typically sort of live in the same room. And we came up with at least a dozen different ways in which in January of 23, when this was published, even prior to the advent of large language models, we had already shown that there was a lot of opportunity to use AI to impact patient safety. So I want to take you through some case studies of things that we've done, talk about some things we're doing, and talk about some things I think that are a huge opportunity. So the first here I want to share with you is chest x-rays. And I want to welcome you again to San Diego, where we're getting our 1 week of rain. It's very cold. We apologize for the weather. But it was actually just about 5 years ago when we got a call from the county who said, we've just accepted one of the first 2 planes from Wuhan, China, full of expatriates. And if we get a patient testing positive for this new SARS variant, would you be willing to care for them at UC San Diego? And without hesitation, our CEO, Patty Mason, said, absolutely, that's what we're here for. And so we actually hospitalized one of the first 5 patients in the US. And I remember at the time, we were spending thousands of person hours spinning up our command center and policies and processes. And I was worried, is this going to be another SARS, kind of much ado about nothing? And it wasn't. And so that's why 2 weeks after the World Health Organization declared the pandemic, I was sitting in a conference room going live on AI to detect COVID pneumonia. So we had spun this up early based off of an accepted paper from one of our radiologists who got a chest x-ray data set from Wuhan and trained an algorithm to identify it. Now remember, March, April of 2020, COVID tests were like gold. I think there were 8 in San Diego County available on a daily basis, and you had to have authorization from the county public health office and the CDC to run the test. And so I was rounding on April 1st of 2020. It was a Monday, and I was talking to the emergency department attending. I said, have you seen the color on the x-ray? What do you think? And she said, actually we saw a patient who was brought by ambulance from a subacute yesterday for possible heart failure exacerbation. We got a chest x-ray to look at the size of the heart. And there was some color on the x-ray. I said, well, what'd you do? She said, well, we called the radiologist. The radiologist said, I don't see any pneumonia. But because of the color, we decided to order this test. I said, well, what did it show? She says, I don't know. It was yesterday. It takes 24 hours. So I'm standing there looking over her shoulder, and it comes back. And sure enough, it was positive. It was actually one of the first community-acquired cases diagnosed here in San Diego. And it was partly because of this AI that we caught it. Now, I followed that patient really closely, and she did well. She was eventually hospitalized with developing respiratory symptoms, probably 3 or 4 days earlier than she would have been otherwise, right? She was isolated, so she wasn't spreading disease. And she did well. She went home without needing mechanical ventilation or critical care. And so to me, this was a great example of AI helping us make the diagnosis earlier than we would have otherwise. But it was still anecdata. And I was trained, we've got to rigorously evaluate these things. So that's exactly what we did. Partnered with some colleagues in the emergency department, and we started asking every time a physician got a chest x-ray, did it help, did it change clinical decision? And we published this in the fall of 2020. Over the course of the summer of 2020, first of all, I found out we do a lot of chest x-rays. We did 2,000 chest x-rays of the 5,000 patient visits. Emergency doctors love their chest films. Secondly, it was easy to use. The color just showed up. But 1 in 5 of those cases, the physician said that it changed their clinical decision. 1 in 5, that's huge, right? So there are a couple of lessons learned here. The first was it was helping. The second was there was an extinguishing effect in the data. Over the course of the summer, it actually got less helpful. How come? What happened by the fall of 2020? COVID tests are ubiquitous, right? You walk in the waiting room, you get screened. And so that's a great example of how it's important to monitor AI, not just when you go live, but on an ongoing basis, because it'll change as the population changes and the algorithms shift and drift. But the other thing I found that I thought was really interesting was a couple years later when I realized that the paper had been cited in this review article. Now, this review article looked at all papers published over a 2-year period that said COVID and artificial intelligence. And the review article found 9,000 articles in a 2-year period. And according to the methodology of this review, of those 9,000 articles, they found that 4 described clinical outcomes. 2 of those were from Israel and Saudi Arabia, 2 of those from the United States. Imagine my surprise to learn that one of those 2 from the US was this article. And let me tell you, this wasn't God's gift to articles. It was like a survey, And so this really highlights a second important learning, which is there is a paucity of clinical outcome studies. I know your large language model can do this really cool thing on this fake data set, right? I know that you can develop a machine learning model to predict something with 100% accuracy right before it's otherwise done anyway. I don't care. And this, to me, feels a lot like 25 years ago when GWAS analysis was getting really popular, the genome-wide stuff. And there were all these sort of papers coming out were about spurious associations that weren't actually valuable. And so the editors got together and said, no more GWAS papers on these small data sets and spurious associations. We need to show biologic plausibility. We need to show real outcomes, right? And so that's the stage I think we're in from an AI standpoint. No more algorithm papers. We need to focus on outcomes, right? That's what's really gonna make the difference. So another area that's very popular, so the gold standard for AI is sepsis prediction. So let me tell you a story about sepsis prediction. I don't think I need to educate this audience that sepsis is a huge problem. In fact, every year across the United States, about 1.7 million adults diagnosed, and about 350,000 die of sepsis. Here in San Diego County, where we have about 3.5 million residents, we represent about 1% of the US population. These numbers hold true. We see about 17 to 20,000 patients on an annual basis with sepsis, 3,000 to 4,000 who die. Now, a couple years ago, we were fortunate to recruit Dr. Shamim Namadi, pictured in the lower right there, from Emory. And Shamim had like $6 million in BARDA grants and sepsis and was excited to come to UC San Diego. I said, dude, you're crushing it at Emory. What do you want to come to UCSD for? And he says, Chris, I've been studying this for 6 years. I've published all these papers. I've never implemented anything. And I said, well, here's our sepsis quality metrics. We have opportunity. So I'd like you to meet Dr. Gabe Wardy. And Dr. Gabe Wardy, pictured in the upper right there, chairs our sepsis committee. And I said, Gabe doesn't know anything about informatics, but Shamim had never sat on a hospital sepsis committee, and I want the two of you to be buddies. They ended up having their first 2 kids at the same time. Their wives are friends, so it all worked really well. You can see one of their first publications here was training his bespoke algorithm how to say, I don't know, to generate trust with clinicians so it's not making predictions when it has low confidence. But more importantly, about 6 months after Shamim arrived, I connected with him. I said, Shamim, you know, we're building all the pipes to put the AI in. You know, how's it going on your side? He says, Chris, I've learned more in the last 6 months than the previous 6 years. I said, well, what do you mean? And he says, well, Chris, like, I've never sat on a hospital sepsis committee before, and I'm starting to realize, like, it's not just about the algorithm. We have to figure out who to alert, and even if we alert the bedside nurse, and he or she doesn't have the ability to order those missing labs, they have to contact the doctor, and that's frustrating. And if we try to alert the doctor, they may not be an electronic health record. So what are you doing? He says, we're working with the hospital transformation team on process reengineering, and we're gonna look at our code team who has some mid-level providers and under protocols can order some of these missing labs. And I said, this is great. And in fact, that's process engineering is part of what we attribute these outcomes to. So a year ago, we published the first ever association between a sepsis deep learning algorithm and a reduction in hospital mortality. So in our then 2 hospital emergency departments, we saw a 17% decrease in sepsis mortality concomitant with AI. In fact, those of you who are local know we've got a La Jolla ED and one in Hillcrest, and we see different populations. And in La Jolla, we saw about a 12% reduction, where sepsis primarily occurs in patients with cancer, because our cancer center is located there. In Hillcrest, we see, on average, patient population immunocompromised who are younger and from other reasons like HIV, and we had a 24% impact in Hillcrest. And so this is a great example of AI developed on our local data set helping us to address disparities in care and gaps in health equity, right? Because it was developed locally and targeted to our patient population. And in fact, even Shamim will tell you that he's very proud of the algorithm, but 50% of the outcomes are not the algorithm, right? It's the people and the process, not the technology. In fact, we traded out his really smart algorithm that could help suggest the diagnosis of sepsis 6 hours before it would be diagnosed on average. Because guess what? If it's accidentally using things like lactate orders, which are actually indicative of clinical suspicion of sepsis, it's not helping the doctors. And they learned that as they ran this in silent mode for 2 years before they turned it on. And so the algorithm now is tuned to look 10 to 12 hours before the development of sepsis and has a lower positive predictive value. But if it does fire, it's more helpful. It's more likely to be something a clinician can intervene on, right? In fact, the editor of this journal, Nature Digital Medicine, Dr. Kvetter, wrote a fantastic editorial all about the paper and things that they thought that the UCSD had demonstrated. But one of the things I really liked is he said, you know, it's time for AI researchers to shift the focus from measuring algorithm performance metrics to meaningful outcomes. And we think that funding agencies and journals alike should be encouraged to prioritize such studies. So again, focus on the outcomes, not the technology. Now, what are some other areas in which we think AI can help? Well, the first thing we had come up with on this Bending the Safety Curve paper was real-time patient safety clinical quality measures, right? And yet, a couple years ago, the team from Johns Hopkins had published this. Anybody remember this paper? How much money does it cost to measure quality? $5 million. Johns Hopkins estimated 100,000 person hours on quality metrics, $5 million just in personnel costs, and another $600,000 in vendor fees. And look at that, of the 162 metrics that are required from a regulatory standpoint, 60% were claims-based, 66% were outcome metrics, 62% were related to patient safety. And so it costs a lot of money to measure this, what we're measuring today, right? So I said our team from the Jacobs Center for Health Innovation on this, and Dr. Namadi and Dr. Bassina and others, again, were able to show that using large language models, they could accurately measure SEP1 measures. In fact, we ran this over 100 charts, random charts, and in 90 of those charts, there was perfect agreement between the large language model and the human abstractor who was manually reviewing the chart. In the 10 in which they were discordant, 4 of the 10 was the person who was wrong, right? So imagine as we start shifting a lot of these metrics to AI-generated outcomes measures, that we can now do this much more quickly. We can improve efficiency. We can present this in real time for actionable interventions. And we can reallocate those resources to being higher value, right? Rather than manually abstracting charts from the rearview mirror, what if those same resources were on the unit, right? Helping educate and intervene. Another example, pressure ulcer prediction. So this is one of my favorite ones, and I'll show you why. Imagine that we had not just devices, but like cameras. So today we use a device that was actually developed in the Bay Area that goes under the mattress for patients who are at high risk of pressure ulcers. And it reminds staff that if those patients haven't been turned in 3 hours, that they need to be turned. The device works. It actually has helped us to reduce our pressure ulcer rates. And there's papers showing that it works. And it costs us a couple $100,000 a year. Imagine if you had a camera in the room and you could use machine vision to observe patients. In this example, this patient, you see the green background, but now look at how as the patient is getting out of bed and is unsteady, it turns yellow. And then as he tries to get out of bed and falls, it turns red. What if when it turned yellow, there was a speaker in the room that said, back in bed, you're at high risk for falling, back in bed, and alerted the nursing staff? Could that AI camera also look at things like patients who aren't being turned and are non-ambulatory? In fact, could computer vision help prevent blood clots like the one I got? Well, we don't know the answer to some of those questions yet, but at UC San Diego Health, we're investigating it. In fact, I'm super bullish on this idea, and it was announced publicly in January that we're working hard with vendor partners to tackle some of the meaningful challenges around privacy and security first and foremost. And then we think there's at least a half dozen different areas of patient safety that AI cameras can help us to address, not just from a measurement standpoint, but from a prevention standpoint. So really exciting area. So I've given you 5 examples of ways in which AI is being used at UC San Diego Health today. And so that begs the question, what's next? So in the last 5 minutes, I want to share a little bit about what we're thinking, and some of this is breaking news. So first of all, incident reports. UC San Diego today gets about 14,000 incident reports on an annual basis. In fact, look at that trend, it's upwards. In fact, I'm really proud of that trend as the former chief medical officer because we want more occurrence reports. We know that increase in safety awareness corresponds to a decrease in safety in harm. However, who reviews those incident reports? Well, they're all text. They all have to be manually reviewed. At UCSD, we have about 39 staff who do that. Now, Chad Vandenberg's here. He's our Chief Quality and Patient Safety Officer, and he's got teams who review the higher severity incident reports centrally, but it's still multiple people. The lower severity incident reports are reviewed in a decentralized way by unit managers and directors and things like that. And then every now and then, we get real harm, and we look back and we say, oh man, how come we couldn't have prevented this IV pump issue? Were there incident reports that would have predicted it? Yeah, there were 3 or 6 or 9, but they were all reviewed by different people. And so the decentralized review misses some of those trends. And it takes a lot of time and effort and people and money. And so just recently, we ran large language models over all of our occurrence reports. What did we find? An overall 74% accuracy just using the incident report on grading severity and contributing factors. In fact, the LLM could identify 85% of actual contributing factors using only the text from the incident report. And our next step, of course, is to feed it the EHR data along with the incident report, which I think is incredibly exciting. And the real mecca is going to be, can we take all this LLM data and predict trends, predict potential harm before it becomes real harm in a way that we never have before? And I'm optimistic about that. And now finally, let me tell you about something I'm really excited about. We were just talking about this morning. Peer review. I know you're all excited about peer review too. 25 years as a practicing pediatrician, I've been reviewing my colleagues' cases. I've been part of the Enterprise Peer Review Committee. And we actually fund some of our physicians to help review charts. But we've got services, maybe you have services like this with 3 doctors, where 2 of them will never criticize the 3rd. It sounds like a common theme. And it takes a lot of time and it takes a lot of money. So what if we could actually analyze and organize complex medical records into a structured patient journey that has source document click-through and view all key clinical events and deviations from the standard of care with references? Imagine if you could upload a 1,000-page PDF and say, was standard of care met in all cases? Would that change the way that you were doing peer review? We think it would. And so we're partnered with a affiliate to look at exactly this. I am so excited about this. I think this fundamentally could not only change the way we do peer review, but change the way we assess risk and outcomes from an enterprise standpoint. And so this is the kind of work that we're doing at the Jacobs Center for Health Innovation, where our mission is innovation at scale with impact. We're incredibly grateful to our local donor, Erwin and Joan Jacobs, who made this possible through a very generous donation in 2023. And we're using this funding to build out mission control with AI for real-time quality and safety. And if you're interested in hearing more, please talk to Chad Vandenberg or myself afterwards. So as I wrap up, I want to ask one more time. Do you think that AI has applicability in assessing and improving the quality of care? Yeah. All right, thank you. All hands up. We do too. That's why we're partnered with National Academy of Medicine, and in particular, Laura Adams, who used to be here at the Institute for Healthcare Improvement. We're excited to be launching soon a whole work stream on AI and patient safety. And again, one of the things I'm incredibly passionate about is not the technology, but using the technology to drive outcomes. And so our recommendation was not to build out a series of labs testing stuff in situ, but rather to use health systems to measure the implementation science and clinical outcomes in the real world. And we hope this is getting a little bit of traction with some upcoming legislation. More to come, hopefully by Anaheim when we meet in December. So thank you very much for your time.